Do you think that you can see the slides?
Perfect.
All right. So I know that we have a big number of colleagues. I would like this to be very interactive as much as you can. So if you have any questions, anything that you want to ask me in the introduction, this would be good. So membership for graduate positions, station 5, I would say every station in the PACES is very important because it examines a bit that you will see every day in the NHS and day work. But I think Station 5, the importance of Station 5 for you as being examined in Station 5 is it had a huge number of marks in comparison to the rest of the, although everything is very important, you have to pass every station to pass the membership for graduate positions, but Station 5 have like 56 marks out of 172, so this is a huge number. I'll just say that I remember that I had my exam, my PACES exam, it was back in Egypt in 2016. And I remember just before going into the exam, there was a very nice examiner. I don't really know his name because we're all stressed during exams. And this is what we're going to talk about shortly. He stepped inside and he said, you don't have to worry about anything. If you try, the only thing, if you try to fail this exam, this is the only way that you fail it. But other than that, if you just leave yourself, you did your best, just go and do what you usually do every day, you will just pass the exam. And this is the thing about PACES, and this is the thing about day-to-day work. When you just started a job, or you just being examined, or someone is just looking at you, you just feel very stressed. And at that point, you don't really do what you usually do. So this is what I need you all to practice a lot. So when you're in an exam, you're not actually under stress, you're doing something that's really automated. And then this was 2016, 6 months later, which is March 2017, I joined the NHS. So I think because I passed the MRCP, so I think anyone can pass it. So just take it easy. And don't listen to anyone say, oh, it's a very complex exam, it's very hard. No, there are thousands of people pass this exam. You can be one of them. So I'll just give you a quick calculation if you want to give. So if you went to station 1 and you got 12 out of 20, which is not very good to be honest, in cardiology, and then in abdomen you got 13 out of 20, and then you get in station 2 and I think it's history taking, I think, or maybe I'm wrong, correct me if I'm wrong, Zaim, and you got 12 out of 20, which is not very good. And respiratory, you got 13 out of 20, not very good. Neurology, you got 13 out of 20, not very good. And communication, you got 12 out of 16, not that much. And then you got 28 out of 28 in both station 5, you would pass the exam. And then at that point, you get 130, I think, out of 172. This is what I'm trying to say. This is how important station 5 is. I don't want you to get all these numbers. I want you to pass the exam, but I'm just saying that station 5 is literally a huge chunk of passing the exam. Station 5's 2 stations, 25 marks each. This is 56 marks, which is a third of the whole PACES exam. This is why we're doing station 5. Zainab did it before, lots of other people did it before. So I think this is very important. I'm not saying you have to pass everything, you have to pass all the skills, but station 5 is a third of the MRCP exam or the PACES exam. All right, just a quick thing I just wanted to know about type 1 and type 2 thinking. Have anyone heard about that? Do you want to put down in the chat if you heard about that? Does anyone know what's that? You want to put down in the chat if you heard about, or you can open your mic and tell me, have anyone heard about type 1 and type 2 thinking? Oh, your star, Benny and Cameron, that's great. So someone knows here. Yep. Okay, anyone else other than Gailan? Shirzad, Gailan or Jailan? Personal thinking, that's great. Yes. All right, so the first day ever that you started driving a car, you're just very conscious. You're aware, if you remember, you're just holding the steering wheel and you just remember, oh, I should push now on the gas. No, I shouldn't look around me. Oh, actually, I forgot to put the car on. All these things, it's just you're conscious. But then by time, within a couple of years, if you see now how you drive a car, you don't really think. When you stop the car because there's a red a traffic light, you don't really think. And this is the difference between type 1 and type 2 thinking. It's the automation. And this is my advice for you in PACES exam. You have to practice a lot, specifically in station 5, to be able to be automated. Why? When you're in the exam and when you step inside and then you start to ask questions like, have you ever smoked? And then you say yes. And then you start to think, all right, so I have to ask him now, how many did he smoke? Oh, how many did he smoke? Oh, I forgot to ask him about the vaping. When you do that, it's not automation. And under stress, you're not going to be able to recall all that. And under stress, imagine all that also when you're trying to find the diagnosis. This is why what I'm trying to say is you have to be automated. You have to do that hundreds of times every day. So now if you ask me how to examine a patient, since the PACES exam, I'm doing that automatically. So hi, my name is Khaled, I'm one of the medical doctors. Can I see your hand? Can you put on the other hand, please? Check his pulse. Can I check quickly the BMs? I would like to check the blood pressure, please. Ask the patient to look to the other side to have a look at the neck and then look at the eyes. What's that? What I'm doing now is the automation that I've been doing for a long time. And I practice that a lot to be able to automatically remember things, whether you use mnemonics, whether you do that every day, whether you use a pillow to do that. I just want you to be automated while you're doing the examination, ask the questions, so that under stress, you don't forget things. Because if under stress, you can drive a car, but if it's the first time ever under stress, you'll not be able to drive the car. So the type 1 thinking, I'm just going to try to put that back. Give me a second. Do you still see my slides? Can you still see my slides? You can open the mic and say yes at any time. I'm happy. Yeah, perfect.
Yes, it's very clear.
So the type 1 is, which I want you to be, is like fast, automatic, often and unconscious. So I just want you to go inside, just ask the questions you've been doing tens of times. How can you do that? You don't have to be, it's very nice to double up with someone or with a colleague, have a buddy that you practice every day, but you actually can do that at home. You can just have a pillow and ask the questions every day. And there is some general questions that you can easily ask people. So like, because for instance, when you do neurology, and this is out of station 5, how to use the English wording, which is, it might be a little bit difficult for someone like me when I started to like, how can I ask them to raise their hand like that? How can I ask them to push their legs against mine? But then by time, I say, oh, I need to practice. How can I use it? And then I find out I can tell them kick. Can you bend your knees? But if you don't do that and you just do it only during the exam under the stress, you're not automated. So you'll have to think of actually translating that into English and thinking of, oh, what's actually diagnosis? Or did I forget something? So what I'm trying to say, please every day practice that tens of times. You don't have to have someone with you. Just use a pillow, ask the questions. So the thing that we do now, if someone just doing that for the first time, he'll be a little bit slow, controlled, is he just thinking of the things, he's just trying to recall things, and then we do the translation in our mind. So I don't want this to happen during the station 5 exam, because if you do it like that with type 1, most probably you'll get the diagnosis and it will go very smooth. Okay, another trick, I know that you have some sessions about tricks and how to do things in station 5, but I'm just trying to give you my own experience. You might use that, you can not use that. Everyone has an own style. So maybe Zainab is doing it a little bit different. Maybe you think, oh, what Khaled is doing is completely different that I want to do. I don't want to do that. It's fine. People are different, but listen to everyone, because maybe someone is doing a way that you actually will cope with it and will make it easier for you. In station 5, before stepping into the station, they give you a paper with the case and the name of the patient you're going to go and the age, and give you a brief about the case. And sometimes they give you the observation of the patient, tell you this patient came with a chest pain or headache or whatsoever. As far as I remember, and just please correct me if I'm wrong, Zainab, they give you before station 5 minutes when you have 2 pieces of paper.
Yes,
then,
that's correct.
Yeah, and then they ask you about that. The thing, and as far as I remember, it was back 2016, they give you a piece of paper that you can hold and you write in it.
Yeah, plain piece, a plain piece of paper with pencils outside on the table, so you could just write whatever you want on it.
My own opinion is you need differentials. You need to put down differential diagnosis. Someone can say, oh, you had this gentleman who came with abdominal pain, or this patient who came with a headache. You have to write differentials down. When the wording is easy, you can write it down. But if it just say patient came with a diarrhea, patient came with cough, how can you write it down? And this is how it becomes a little bit difficult for someone. And not me only, but me and lots of my friends, we started to do something which I think is a little bit interesting, which is trying to get to write down all the differential diagnoses for all the cases, for all the presentation that we will see. And then by time we found out that, oh my God, so I write down, so if someone asks me about cough, I write everything down, but actually forget cancer for some reason. Or if someone asks me about abdominal pain, I remember everything, but I forget about AAA. And then we try to track the patterns, and then I got something that I use a lot, and I think that you can use that yourself, or you can tweak it a little bit to write down the things that you miss. So what I usually do is I just write the most common, and then the most serious, drug-induced, trauma, because I always forget about trauma, and then infections, HIV and TB, we always forget about that. Even if we write infection, someone who comes with a cough, you will write pneumonia, but possibly you're going to forget about HIV and TB. Endocrine and autoimmune, all that we tend to forget for some reason, or maybe that's me. Maybe you can tweak it how you forget things. And then I added system and systems. When I mean systems, so if someone comes with a chest pain, after I put down the most common and the most serious infections, everything, I write down things. So the system that the patient came with. So the patient came with a chest pain. Let's start with the chest wall. Okay, musculoskeletal. The bone itself, maybe the patient has some trauma. Oh, what's below the chest wall? The pleura. Oh, actually maybe some pleurisy. So this is how I wrote it down. And then I go quickly through the systems. If you do that for every presentation, you can write down, I guarantee, more than 10 differential diagnoses, which I think is just more than enough. So what I'm going to do now is quickly, I'm going to just open the chat to make sure that you're actually following up with me. Let me see. Yeah. All right. So if I'm going to go a little bit back. Yes. Can you see pain, including headaches? Can you see that? You can open the mic.
Yes, it's very clear.
Okay, that's perfect. So the only exception I usually use is the Socrates for pain. You know, have you ever heard about Socrates for pain? Pain have a very specific thing, very specific approach. So I'm gonna quickly do a quick workshop just to see if the differential diagnosis thing is gonna work or not. So let's jump into, ignore that now. Let's jump into second cough. All right, quickly, cough. What's the most common? Can you write it down in the chat? Perfect. Upper respiratory tract infection. All right. That's lower respiratory tract infection. Allergies, maybe. Asthma, COPD, pneumonia. You're a star. Oh my God. That's great. More serious. Cancer. That's great. Oh my God. Do you have the presentation? ILD. Yeah, you might. Yeah. Drug induced. Methotrexate, yeah, interesting. NSAIDs, ACE, that's great. Amiodarone, perfect. Trauma, well, you can say some dust, smoke. Yeah, maybe this is not really specific, but you can think of that, or you can actually ignore it. Infections, HIV, TB, pneumonia, endocrine, Strauss, pyoma. System, if I think about a system in the lungs, I'm going to think of pleurisy, PE. Systems, the other system, I'm going to think about stomach, I'm going to think about gourd, sensory neuropathic, and congestive cardiac failure. I think about the rest of the system that might cause the patient to have cough. All right, back pain. Anyone interested? What's the most common cause of back pain? Mechanical, muscular, yeah, perfect. COPD, oh, what's that? No, sorry, I think I did something wrong in this. Ignore that. Yeah, we're back here now. All right, perfect. So mistake. More serious would be called equina. Right, what else? Disc, yeah, perfect. Someone wrote down the disc. Osteoporotic fractures and Mets. That's good. Cancer. Yeah, that's right. Cancer bone. Great. Drug induced. Would you think of something that causes back pain? Steroids. Wow, that's great. Yeah. Statins. Muscular pain. Yeah, can be. But I never thought of steroids. But do you see that? This is how you get. And when I say most common, mostly is drug induced and trauma, actually something. Why I wrote trauma down? Because I always miss trauma. Me as Khaled, I always miss trauma. So I do everything, but then I must miss trauma. And for some reason, I miss autoimmune diseases. So I do everything and I miss that. This is why I added that. So if there is, if you're pattern that you usually miss trauma, just write it down by its own. If you remember everything, but you tend to forget the most common. So either go with my mnemonic or the way I do it, or just do your own thing. What I'm trying to say is this is not only going to help you when you step in and ask the patient the question, because you will step in and you know that you know 10 things that possibly the patient have one of them. All right. So this is very important. I want you to have your own way of approaching the differential diagnosis. Mine might be nice. You might like it or not. Maybe you have your own thing. That's it. Do it. All right. Okay. So how to approach history. I'm not going to talk about that. I'm just going to run quickly through it. I think everyone has his own way. Whatever you do to be able to approach the history, make sure that you do that hundreds of times. So when you step in, you can easily ask the question. So I do it in threes. For instance, when I ask someone about social, I ask about social, and I then think, oh, when they're at home, how's things at home? When they're at work, what do you do for a living? We're in the streets, do you drive? So you have your own way or own mnemonic or whatever, but do that tens of times. So my approach for history is just introduce myself, and that what brought you in today, an open question, and then I usually ask onset, course, duration. For all the complaint the patient came, what increased, what decreased, and associated symptoms. I always ask the unit variation, and I don't ask only the unit variation, but I ask them if the patient come with a cough, is it more in the morning or evening? Is it more at the beginning of the week or the end of the week? Is it more certain months of the year or not? I usually say not only the day, but all the time. So the day, the weeks, and the month. And this is, you can see that in cough, for instance, in patients with asthma. So variation is very important. And then after that, I ask a question for every differential diagnosis I wrote down. So for instance, the patient who came with a cough, the most common is lower respiratory tract infection that you just said. I'm going to ask the patient, are you coughing any phlegm? What's the color of the phlegm? Is it green, yellow? Do you get any fever with that? You put cancer. Are you losing any weight? Any temperature? Any sweating at night? And if I put down something like in, let's say in the back pain, for instance, the patient has slip disc. Do you have any numbness in your legs? So I put a question for every differential. If you go with this, by the end of asking a question for every differential, you possibly have reached the diagnosis, or at least you made it down to one or two differentials. And I would like you to know something. I know that lots of you are actually very experienced doctors anyways, but you know, in medicine, most of the time, we don't really know the diagnosis. And what we write down is provisional diagnosis. I remember very good that when I I got a very good mark. I think it was in cardiology. I think it was a cardiology. So anyways, so my approach is in when I listen to the patient's chest and I hear a systolic murmur, I'm not really sure, is it actually radiating or not? This happens to us every day. In the exam, the examiners are actually doctors. So if you're very lucky that you know that this is a harsh systolic murmur and it's going to the patient's neck and radiating the patient's neck, and you know that this is aortic stenosis, that's nice. But if you're not able to pick this up, they will really appreciate that you give them a differential. I usually tend to say, I can hear a systolic murmur, I think it's radiating to the patient's neck, but I would like to confirm my diagnosis by doing a heart echo. My differential would be, my first differential would be aortic stenosis because this, and that, but it actually might be something else because of this, and that. So I think if you don't reach the diagnosis, it's not the end of the world because you don't have the echo. All right. So they know the echo, they saw the result that says this patient have aortic stenosis, but you don't have it. So what you usually say is, I think that's my diagnosis like that, but my differential is what, because you don't have blood results, you don't have echo, you don't have chest x-ray, so you don't have the answer yet, but you're actually putting your provisional diagnosis. I'm just going to go down to questions. The differential red flags, don't ever forget red flags, please. I do that even in my practice. Whenever I asked if the patient came with anything, I was asked about red flags. If you got the answer, and if you think, oh my God, yeah, I know this patient having pneumonia. So I usually ask about 3 things. What caused that? What is the associated disease that might come with that? What the complication of this disease? I can send you the slides at some point, but I'm just going quickly through it just a refresher for you, because I know that Zainab gave that before. Past medical history, I like the 3s. So I like past medical history, I like medical, surgical, and family history, and then social, sexual, smoking. I drive from home to work to the pub. This is why usually I remember it. So I drive. So do I drive or not? From home, how things are at home, to work. So what do you do for a living? To pub. I asked about alcohol consumption. Medication, including over-the-counter medication, herbals, and allergies, and concern. I'm sorry that I wrote concern very, very small, but it's very, very important. If you miss the concern, you might actually fail the station. So always remember. So if you reach at some point and you're examining the patient or whatever, and they said 2 minutes waiting, 2 minutes remaining, stop. So if you're finishing a sentence, fine, just finish it, but then jump to the concern, because you might have someone who came to you and told you, all right, so I came with a chest pain or whatever, and then you end up by saying, all right, what's your concern now? And then you find out something very concerning, that I'm concerned that I might have cancer because of something else that happened. You have to ask about a concern, or I think that this might cause you to fail the station. All right, this is the quick thing. So I think that, Zainab, we have volunteers, right?
Yes, Khaled, we have 3 volunteers.
Yes.
So before we start, if anyone has any comment or any question.
Does anyone have anything that is worrying them about station 5, or anything that you think is not clear? And by the way, this is the time that you have to speak. Other than that, no one.
All right. Everyone's satisfied.
Everyone is happy. All right.
Okay. Do you want to start now with the scenarios?
Yes, I'm happy. Yes, I put the case number 1 on.
Okay, good. So I think we are starting with Amir. Amir, are you ready?
Yes, I'm ready.
Good. Good evening. So
Good evening.
I'll be the patient. Okay.
Yes.
And
can I
yes.
just give you a couple of minutes?
Yes.
When we finish when we read through the patient, I want to give them a couple of minutes to put the differentials. Is that all right?
Yes, it's your session, Khaled. So you design it the way you like.
So Amir, So patient, we have Miss Lisa. So go on. Do you want to change? I think you made some changes. I think.
Don't worry about it. Just
Do you
leave
want
it
to
as
go on?
is.
Just go with your. Do you want to put your slides on?
No, keep your slides.
Are you sure?
That's okay. I'm sure. Keep your slides.
No.
Yeah, it's just a name change. It's not a big deal. Fine. So we decided just to keep English names, just to give you a sense of NHS. I hope you're happy with that, but doesn't matter the name, mainly the history and the story, what matters.
Okay. You can say it's Zainab Yusuf. It's fine. You can go with that.
You can, yeah, I can say my name, doesn't matter. So do you want to time, Khaled, or shall I do the time?
Yeah, I'm gonna time. Yeah,
you're gonna time.
Yeah.
Fine. So because each candidate will be doing one case, so we'll give you 2.5 minutes for each case, and then we finish the case, we discuss, and then we go to the next one. And instead of doing it the way I did for full 20 minutes, because we want more interaction. So we learn from our experiences. Are you happy with this plan, Amir, and everyone?
Okay. Yes, I'm preparing for the case. Do you want me to start now?
Okay, so can I just say it's Miss Lisa Best, 36 years old lady. You're a doctor in the medical admissions unit. The patient came with a severe headache. Do you want a couple of minutes for defenses, or are you already ready and wrote it down? Did you write
I
it
think
down?
I'm ready. Let's go.
We'd like to have some time.
Yes, I put some differentials on my paper.
You already did, you say?
Yes.
Okay, that's perfect. All right. Do you want to start? Now, here you go.
Okay. Hello, good evening. Hello?
Zainab, you're on mute.
Hi, good evening. Hi, doctor.
Good evening. My name is Dr. Amir. I am one of the doctors in the medical unit today. Can I confirm that I'm speaking to Ms. Lisa Best, 36 years old?
That's correct.
Nice to meet you, Ms. Best. So, Ms. Best, we are here today to discuss about your symptoms. Will that be okay with you?
Yes, please. Yeah, go ahead.
Okay. Can you tell me what seems to be the problem?
To be honest, I've been having problems with quite an intense pain in my head for the last few days, which is really getting worse, and I'm not coping with it, particularly today. That's why I'm here in hospital. Thank you.
Okay, so before we proceed any further, do you want a painkiller for this headache?
At the moment, no, fine. I was given some paracetamol, but it's not touching it.
Okay, so you said it is like for the past 1 week?
No, it's lasted for the past few days, like 2 or 3 days ago.
Past a few days, okay. And this is your first time having this headache, or is it a regular or a recurrent headache?
Well, you know, I have the usual headaches everyone has, but I've never had such headache before. This is like the worst headache I've ever had.
I'm sorry to hear that. So you said this is the worst headache. So on a scale of 1 to 10, how would you rate your headache?
Well, to be honest, it started like 2 out of 10, but at the moment it's I would say 8 out of 10, 9 out of 10.
Okay, and is it started like suddenly or gradually?
I'm trying to remember now. I think it started, as I said, it wasn't that intense. It was 2 out of 10, but it's getting worse and it's getting more intense at the moment. So I would say gradually building up.
Okay. And where exactly do you feel your headache? Is it like in front of the headache, of your head, or all over the head?
It's all over my head, but it's mainly here on the front.
Mostly on the front. All right. And okay. And is there what do you think makes it increase or makes it worse?
I'm not sure, to be honest. I can't think of anything. Hello? Can you hear me?
Yes.
Yeah.
Yeah.
I don't know, to be honest. I feel I struggle when there's any like a bright light, any loud noise. It makes me feel worse. And yeah, I mean, any activities I do, I feel I just want to go somewhere quiet, rest, just to make it feel better. But nothing seems to make it better.
Okay.
Barely settles. Yeah.
Right. I'm sorry to hear that. So is it an increase when you bend forward?
Kind of, but not really. A little
is
bit.
It more? Okay. Is it more in the morning or all over the day?
Mainly, well, it got worse this morning compared to the other days. It got worse this morning when I woke up.
Okay. And do you feel sick, or have you vomited up or thrown up?
I feel sick, but I haven't really brought up anything at the moment. But I just feel sick.
Okay. Do you have any neck pain or back pain with it?
I don't have any neck pain or back pain, no.
All right. Any temperature?
It's like, yeah, I feel hot a little bit. And I checked my temperature. I think it was slightly raised. I have a thermometer at home. Yeah.
Any vision problem?
Yes, my vision is getting blurry recently, which is unusual to me. I don't wear glasses normally.
Okay, I'm sorry to hear that. And is it on one eye or both of eyes?
Both.
And when you say blurry, when you see blurry, do you see double or only blurring of the vision?
I noticed I had some issues today. I think I saw a double today. I'm not sure, but I think I did. Yeah.
Okay. And
things are not very clear when I look at them. Yeah.
Okay, we will try to solve this. Of course. Is there any weakness?
I don't have any weakness, no.
Any tingling or numbness?
No.
Okay. Any problem with the speech or swallowing?
I mean, I'm speaking now. I don't have any issues with that, no. And I haven't had any issues with the swallowing. Yeah.
That's good. Any abnormal movement, maybe?
I don't have any issues with that, no.
Any loss of consciousness?
No.
Any problem with your bladder work or water work or your bowel?
No. No issues with that. No.
Okay. And do you have any past medical history of note?
Well, I have been diagnosed with the Crohn's disease, but at the moment I'm not on any medications. I was told it kind of settled, or they use the term remission. But yeah, so I'm not on any treatment. Yeah. So
you don't take any treatment for it right now?
Nothing for Crohn's, no.
Okay. And you said regarding your drug list, do you have any drug list? You said you don't take any medication, any over-the-counter medication maybe?
Nothing, of just paracetamol.
Okay. I want to examine the patient. I will examine the eye of the patient, looking for diplopia. I also
some slight diplopia when you move your hand to the right side. Other than that, you have some temperature, but there's nothing else. What are you going to examine other than?
Okay. I also want to examine for neck stiffness.
Yep. No neck stiffness.
All right. And so, Mrs. Best, what is your concern?
So, I'm worried, to be honest. Can you hear me properly? So,
hello? Your voice is low.
Yes. Can you hear me now?
Yep. Yes.
To be honest, I'm really worried that could be a cancer. Is this a cancer in my brain?
So, I really appreciate your concern, Ms. Best, but at the moment, I don't think it is really a cancer problem. I have other diagnoses in my mind. It is very important now to maybe admit you to a short stay unit, do some blood test and maybe some imaging of the brain. And we will have another sit down to discuss about the results of the investigation.
So it's not cancer. So it's not cancer.
I don't think cancer is a remote possibility here. I don't think like it is a cancer, but we will have to look into it more.
All right, so I'll stay in hospital today.
At least for short term until we do some investigations, maybe.
All right, okay.
Will that be okay with you? Okay.
Yes, I'm fine. I just need to get rid of this pain.
All right. So do you smoke?
Well, I used to, but I stopped smoking.
Okay. And do you drink alcohol?
Yeah,
No.
I think time has done for 8 minutes past. All right.
All right.
So, I mean, do you want to tell me what you think is happening with the patient?
So Miss Elizabeth, 36 years old, presented with headache for the past several days. She said this is the worst headache ever, and it is associated with a slight temperature. And I think it is of moderate to severe intensity that's impacted the patient daily living, and she cannot do anything. There is no features of, there is also photophobia maybe, but there is no features of meningitis or subarachnoid hemorrhage, that although I have to look into it to rule out these serious diagnosis first. And there is no features of raised intracranial pressure maybe. The patient didn't report any headache with bending forward or at the early morning.
Do you have a provisional diagnosis?
So my provisional diagnosis, I have to rule out first subarachnoid hemorrhage or meningitis because the patient having fever, and although there's no neck pain, but she has a high headache with vomiting. I have to rule out meningitis in this young age, and also I have to rule out subarachnoid hemorrhage. Another thing I have to rule out cavernous sinus thrombosis. Maybe the patient is having diplopia. It is very important to ask about any history of flu-like symptoms or maybe any procedure, maybe any dental abscess or procedure.
All right. So can I ask you what test do you want to offer the patient?
So I want to do, first I will have to do a CT scan first to rule out subarachnoid hemorrhage. And another thing, I will do an MRI and MRV after if the CT scan is negative. Okay, and also I will send for a basic investigation form of complete blood count, CRP, and ESR to rule out infection. Maybe if there is negative imaging, I will do an LP after 12 hours, maybe to rule out subarachnoid hemorrhage if the CT scan is negative. And so, yeah, I think these are the investigation now. Yeah. Her examination was normal apart from diplopia only.
Okay, I think that's it. I think we're already past another 2 minutes. Can I start with I don't know, should I ask, thanks a lot, Amir, very much. Is it Amir or Amir?
Yes, it is Amir.
Amir. Thanks a lot, Amir. I think you did all right. So can I start with taking feedback from everyone? So I want to start by asking people, and can you put down in the chat, what are the good things that you think Amir did? I want only good things for now.
Positive comments.
Yeah. Sorry, what was the question? What the?
I want to ask, what do you all think Amir did well?
What things he did well?
Yes.
Okay, I think the investigation part was good.
Yep. Good. And someone said he did not forget his concerns, very important. Good approach and manage patient's concerns, that's very good. Comprehensive history welfare of the patient workup, that's great. He took patient consideration of concerns into account. This is very good. His differential diagnosis, I think this went right. Yes. Yes. All right. So can I ask the other way around? What can Amir do to make things better next time? So I agree that he did all these things, and maybe there's a couple of things I'm going to say next that did well. But what do you think he can do next that will make it better? Manage time correctly, all right? what can he do next time to make things better?
I think he can exclude other common causes of headache, like cluster headache, a migraine, and trauma, use of blood thinners, these kind of things, and maybe ask more specific history about these differentials.
Yes, yeah. He didn't offer ophthalmoscope. So I would say that next time it would be nice if he offers ophthalmoscope. Yeah, fundoscopy, yeah, nice. Quicker history, yeah, that will make things easier. Migraines and sinusitis, maybe fundoscopy before. All right. Okay. So I'm going to give my feedback on spot. Zainab, first of all, as a patient, what did you feel?
So as a patient, he had empathetic approach.
Yeah.
He wasn't. He was showing empathy with every step when he was asking. Whenever I was mentioning that I'm struggling, he didn't waste the opportunity to show empathy. I feel he needed to be a little bit quicker when he asked questions and be a little bit. I know he had the differential diagnosis list in his mind, but he didn't cover it all properly, I would say. I mean, I know the diagnosis, so I'm kind of biased here, but yes, just more efficient use of time, which comes with the practice, of course. We just need to use time more efficiently to make sure that we cover everything. But yeah, as a patient, there was empathy. Patient welfare wasn't invaded in this scenario, I would say. But let's remember, he didn't spend time to examine. He just asked a few questions of examination. So most of the time was history. But this is not the real case. Yeah.
Yeah. So with saying that, I think, I mean, who's very professional, to be honest. The way he asked the question, I think, and it sounds to me that he's very experienced, because I think that he picked up the diagnosis anyway. So he put in his differentials the diagnosis, I think. And what I want to say is, to be honest, 6 minutes is, oh my God, this is a very limited time for you to do everything. But when you walk in the NHS, you know that we tend to do that. So in a brief consultation, you actually will do that. And I think that you had lots to offer, but you were very limited in time. But then you would have to do that in 6 minutes at the end of the day. Let's say it's maybe perhaps they can give us more time due to the technical issues. Well, so can I tell you something? When I was practicing with one of my friends, we knew that we had 2.5 minutes for the differential diagnosis. We used to give ourselves 1 minute, and then we knew that we had 6 minutes, but we used to give ourselves 5 minutes, because we want to be, because in the exam, because of the stress, we need more time. So actually, I would say that I agree that the time starts once you enter the room. I think that you have put 5 minutes as your time, and then by time you will utilize your time better. The relaxed way, I mean, that you were asking, actually, it sounds to me that you're a very good experienced doctor, and you shouldn't be. You did very well. Specifically in the exam, you have to take like faster approach, kind of. So you have differentials in your mind, or you write it down. You have to ask the question that needed to ask. And also, there's something which is very, very, very important. She's called Miss Best. You said Mrs. Best. This sometimes make a bit of a difference. So it's written Miss. Please say Miss. Don't say Mrs. And when asked about cancer, don't say I don't think it's cancer. You don't have any imaging. You don't have any. You do not complete the history. You don't ask. You did not actually ask about red flags, so you can't really say that it's not cancer. You don't have. You did not ask about the family history. So I think you can say, I would think it's less likely that it the wording is very important. I would think it's less, or you can say cancer would be at the bottom of my differentials, but we would exclude that, or we're going to do the imaging just to make sure that we address the concern. I think Fikra al-Wattar is raising her hand. Is that right?
Yes, it's Dr. Dhikra al-Wattar. She's one of the PACES examiners.
Yes, Dr. Dhikra. Do you want to? I think you're on mute. Do you want to unmute?
Sorry?
Yeah, that's it. I said that you were in mute. I think you're still on mute. Do you want to unmute? Sorry.
Can you hear me now?
Yes, I can.
Okay. So good evening, and thank you for the lovely presentation you did, and very lovely case history, and the feedback you gave to Dr. Amir. As you said, I think he is, with a little bit of touch and practice, he is ready to pass, hopefully, his full PACES exam, because he approached this scenario in a very nice way, introduced himself, and he was very empathetic with the patient, saying that if you are in pain, do you need me to give you any painkiller? Or so it showed some concern and some caring for this patient, who probably he assured her. And what is the more positive about his interrogation with the patient is he asked about the patient medication list, which is very important to ask in this station in particular, and also the effect of this headache on the function of every day. So that was very assuring. And also if she has any other symptoms which probably direct him to the correct differential diagnosis. I liked his way, in a way not falsely assuring this lady that it is unlikely to be cancer. I agree with him. I mean, a headache for only started the past week or so, highly unlikely to be cancer, but yes, it can be, but at the bottom of the list. So he was in a way assuring her that I want to rule other things like simple viral infection, meningitis, whatever other differential diagnosis. But he was very right in approaching that, because she was very concerned, is this cancer? And he was like, in a nice way, said, unlikely to be cancer. But again, there will be another meeting, another investigation. And he was very safe that he admitted her to the hospital, or he will admit her and arrange the right investigation. Even he's considering lumbar puncture, considering doing MRIV, because he wants to rule thrombosis. The negative thing, as you have mentioned, and my other colleagues, is he did not say, can I have the ophthalmoscope to look at the eye? The examiners may say, we don't want you to do that because the fundoscopy is normal or whatever. So I think for Dr. Amir, in this scenario, I am very satisfied. And if you are the examiner, I don't know what will you score him, but I will score him as satisfactory, knowing that he didn't have the chance to examine the patient. But I think he is in need, as everyone, to practice every day, even at home, when he sits in front of a recorder and pretend he's talking to a patient. So he can speak fluently the way the examination expectation of the exam. So thank you very much. Thank you, Dr. Amir, you did very well.
Thank you, Dr. Wattar.
Thanks a lot, Dr. Wattar.
I think there was an issue, they couldn't hear me properly. That's why Amir was taking a long time. I'm not sure if my voice is clear or.
No, your voice is clear.
I changed into my mobile phone, which keeps sliding down and falling apart. So hopefully, yeah. But yeah, thank you so much, Dr.
All right. So I mean, got a very positive feedback. So I think this is what I say every time: is you have to build on the things that, so your strength that you have from everyone, you have to build on that. It means that keep it up. and build on that. And anything that you heard as a negative, it doesn't really, it shouldn't be really negative. It's things that you have to work on, as we say here. So I think this is, you got a very good feedback possibly from everyone. So just keep it up. Do you want to go for the next?
I think Rand wants to ask a question.
Yeah.
Yes, so is this a case of differential diagnosis, or what is the exact diagnosis here?
All right, so we put this case down as the thing that he picked up, which is cavernous sinus thrombosis. So I think he reached the diagnosis anyways. He put the differential diagnosis and it was a cavernous sinus thrombosis, wasn't it, Zainab?
Yeah, it was. And if you digged, so I told them before, any young female patient or childbearing age, please ask about pregnancy. So this patient had a baby 2 days ago, was it? Yeah. So this patient had a baby 2 days. She's postpartum, high risk of BVT.
Yeah.
Yeah. Please don't forget pregnancy and anything related to pregnancy.
Yeah. So I would just say something which I think is a little bit very important, which is sometimes in the history, we put lots of things and sometimes you miss it. But sometimes overall you're doing very well and you're approaching the patient very well, putting lots of differential diagnosis. The examiners know that you're actually very limited in time. And that if you miss something, it's fine. Because lots of people say, oh my God, if I miss the pregnancy, this is a huge thing. It wouldn't be very nice, but it would not fail you or do not make you, oh, we're going to give him 20 out of 28 because he missed the pregnancy. But if you get that, it'll make actually your life a little bit easier because this will increase the probability of your differential diagnosis. But I think my opinion, if you give a very good differential diagnosis, it will make you feel better, and I think the examiner will be more satisfied. All right. I think the second case, Zainab, do you want me to do that? To be the surrogate, and you do the other way around because it's
no, please, it's your session, so you do the judgment part. I'll be the patient.
No, actually, I'm happy to be the patient, be the patient, and then give the feedback anyways, because everyone's giving the feedback. I'm happy with.
We have female patients and male patients. Let me do the female ones. And
yeah, no, it's okay. Did we start with the?
So the second candidate is going to be Rand.
Yes.
Rand.
Yeah.
You are ready?
Yes.
Okay. Khaled, if you could just share your screen so that they see the case.
Do you see it?
You haven't shared it yet.
1 second. Share screen. That's it. Yeah. You see it?
Yes.
Okay, it's Miss Asia Begum, 26. You're a doctor in the same day emergency care, and this lady presented with chest pain. The respiratory rate was 23, heart rate 105, blood pressure 120 over 70, which is normal, temperature 37, saturation 94% on air. Do you want to have a couple of minutes for differentials, or do you want to start?
Yes, 2.5 minutes I have, right?
Well, I'm going to give you 2 minutes, is that right? We can ask the rest of the team to quickly write the differential just as a practice. If you have a patient came with a chest pain, just write down the differential.
I think I can start.
Yeah, perfect. Good. You
Okay.
start.
Yeah.
Yeah, Bhutan, start it now.
Hello?
Yes, go
Hi.
on.
Okay. Good evening.
Good evening.
I am Dr. Al-Radi, one of the doctor here in the emergency unit. Am I speaking to Miss Asia Begum, 26 years of age?
Yes, yes.
Nice to meet you, Miss Begum.
Nice to meet you too.
Ms. Begum, I am here to ask you questions about your condition and examine you. Will that be all right with you?
Sure, definitely.
So I can see from your notes you are having chest pain. Can you tell me more about it?
To be honest, a few days ago, I started having pain, and which is really annoying and really concerning, to be honest.
Okay, I'm really sorry you are going through this. We will try to find out what is causing this and give you a painkiller by the end of this consultation. So you are telling me it started a few days ago. How did it start? Can you tell me, is it started like gradually or out of sudden?
Well, it's kind of a bit of both. I suddenly started, I started feeling this pain, but at the same time, it started increasing in intensity quite quickly.
Okay, can you show me exactly where do you have the pain in your chest?
It's mainly here on the left side of my chest.
Okay. Is it getting worse now?
Yeah, kind of.
Okay. And what is the character of your pain?
What do you mean by the character of my pain?
How can you describe your pain? Is it sharp? Is it squeezing?
I would say it's sharp.
Okay. Does it increase with breathing, taking deep breath in?
Yes, it does. Yeah, I noticed that. Yeah.
Okay. And if you could score your pain to me from 1 to 10, 1 being mild and 10 being severe, where would you put it?
I would say 7 out of 10 at the moment.
Okay. Is this the first time you're experiencing this chest pain?
Yes, I've never had such pain before.
Okay. And have you traveled recently anywhere?
I did. Just like I was driving in the car for a long time.
Okay, so you didn't take any, like a plane?
I didn't take any plane. No, I was like traveling, driving.
Okay.
Mainly.
Did you have recently any kind of infection, like any sore throat or raised temperature?
No, not really. No.
Okay. And did you have any like racing or pacing of your heart?
I haven't noticed that, to be honest. No.
Okay. Can you tell me more about it?
No, I haven't. I haven't noticed any issues with my heart. Yeah.
Okay. And do you have any cough?
Just like a normal cough when my throat gets irritated. That's it. Nothing unusual.
Okay. And are you under a lot of stress recently?
No.
Okay. And did you get any trauma, especially chest trauma or any injury? Did you lift any heavy objects?
No, I haven't.
Okay. Have you been diagnosed with any medical condition in the past?
Well, yeah, I have high blood pressure, I have diabetes.
Okay. So I can see from your notes that your blood pressure is normal. Are you taking medication for that?
No, I'm just like diet controlled.
For blood pressure?
Yes. They just asked me to just low salt diet, exercise,
okay.
loss, lifestyle thing. Yeah.
All right. And what about your blood sugar? Are you in regular checkup with your GP?
Yeah, they're the same diet controlled. Yeah.
Any complications related with your kidneys?
No issues with that. No, I don't have any
Okay.
issues.
Any recent weight change?
Well, I've been trying to lose weight to control my diabetes and high blood pressure. So.
Okay. And did you have any recent surgery or procedure done or any hospitalization?
No.
Do you take any medications, including over-the-counter or herbal medications?
No, I don't take any medications.
Do you have any allergies?
No.
Okay. And do you take any birth control pills?
No.
All right. So how is your period? Is it regular?
Well, I'm pregnant.
Oh, okay. Congratulations.
Thank you.
So, how is your pregnancy going so far?
Perfect.
Okay. Is this your first pregnancy?
Yes.
And how far are you in your pregnancy?
30 weeks.
Okay. Did you notice any leg swelling?
Yes, I noticed that. Yeah.
Okay. Okay. And is there anyone in your family who is having any chest problems or blood clotting problems?
No,
Okay. And do you smoke?
I do. I
Okay.
stopped just before pregnancy.
Okay, that's really great. And do you drink alcohol?
No, I don't.
Okay. And where do you live? Is there anyone taking care of you?
Well, I live with my husband.
Okay. Do you have enough support at home?
2 minutes
I don't
remaining.
need any support at the moment.
Okay.
I'm okay.
Okay. So, Ms. Begum, can I examine you now?
The recording has stopped.
Okay. I
Yes,
would like
ma'am.
to listen to your chest, your lungs.
Yeah.
So the examination are fine, chest is clear, abdominal flat, and there's nothing in the examination.
Okay. I'd like to listen to her heart, check
Yes,
any
fine.
for murmurs or any palpable P2, any JVB is it raised or not.
No, everything's fine.
Okay, I'd like to check her leg if there is any swelling in her legs.
Yeah, both legs are swelled, more at the left side.
Okay, I'd like to check her blood pressure as well.
Yeah, it's normal as before.
Okay, so what is your concern, Ms. Begum?
To be honest, I'm really worried about my baby.
Okay, so Ms. Begum, your concern is valid. I am suspecting you are having a problem with blood clotting due to your pregnancy. That's why you are experiencing this chest pain. And at the same time, it could be due to other reasons. So what I will be doing for you is you will stay with us in the hospital. We will run some blood tests and some scanning and some imaging of your chest to rule out what is causing exactly your chest pain.
Will these tests affect my baby?
Well, if it's not managed immediately, it can. So we will make sure of that. I will involve the respiratory specialist and also an OBGYN in the same time. And we might need to start.
Who are they? Because I missed that. Who are they?
We will involve a respiratory medicine specialist and an OBGYN specialist, which was related with pregnancy.
Will these tests affect my baby? Yeah, that's fine.
Yeah, time.
Yes.
Yeah. All right. So I think it went well. Can I start taking feedback from the audience?
I'm sorry, as examiner, will you ask me questions?
Oh, sorry.
Yes,
I think we have a question from Adyan Al-Qassam.
Adyan, yeah.
Yes, hello, doctor.
Hello.
Yes, it's Adyan Qassam. Yes, Adyan Qassam.
Yeah.
So, hello. Dr. Rand, you did a great job. That was really, really nice.
I'm really sorry. I think that, Adriana, we're going to get back to you. I completely missed to ask her the question. So I'm going to ask
Hold
the
that thought, Adyan. Hold
and
it.
then no, it's my fault. It's not yours. All right. Okay. So quickly, sorry, can you remind me your name? Rand.
Dr. Rand. Yes.
Rand. Dr. Rand.
Yes.
Okay, Dr. Rand. Tell me, what do you think is happening with the patient?
So since so I have Miss Begum, 26 years of age. She is in her third trimester of pregnancy, of her first pregnancy. She is complaining of chest pain, which is pleuritic in character and scored 7 out of 10, which started suddenly a few days ago and it's getting worse. She denies any history of trauma or travel history or any flu symptoms or any cardiac chest pain. So my main differential is that she is having a pulmonary embolism due to her pregnancy. That would be my first diagnosis.
What's the other differentials that you have?
My other differential would be a musculoskeletal chest pain, although she denies any history of trauma or fever. And my other one would be maybe something related with pericarditis, perhaps. So I would like to rule that out as a possibility.
Yeah, right. Okay. What test are you going to offer the patient?
So first, I would like to check her blood pressure, bedside blood pressure, and ECG, and chest X-ray, and then I would like to order some echo as well. Then for blood test, I would like to rule out any infection. So I would like to look for any inflammatory markers, ESR, CRP, and I would like to check her coagulation profile and D-dimer as well. Liver function test and kidney function test, since she is having diabetes and high blood pressure. So excluding, and also a urine analysis to exclude any proteinuria to rule out preeclampsia and this kind of condition.
Did you offer her, sorry, did you offer her scan?
Not yet. I just offered her measure her blood pressure and urine analysis to check for proteinuria and blood sugar as well. So I would like to, since she is pregnant and after checking her kidney function test, I would like to, I would like to order a VQ scan for her, since CT is not safe for her. So, and start her on, yes.
Yeah, I think time has passed. I just want to clarify something regarding the CTP. I think it gets confused for lots of reasons regarding the CTPA. In patients who are pregnant, CTPA is high risk for the mom to get a cancer breast, and the VQ scan is high risk on the baby. So it depends on the trust and depends on where you work, but sometimes you offer the patient, you tell them, would you like to have a CTPA that might cause you theoretically to get breast cancer at some point? Or do you want to get a VQ scan, which is high risk on the baby rather than you, but less risk on you? So the CTPA is high risk, not on the baby. Oh, yeah, so I'm getting some feedback what you ran. I'm just going to quickly read. Nice history approach. And then very well done, very great approach about the detail of pain, like radiation of pain. Okay. Amir, great approach. I think that concern was not properly addressed regarding the baby. No need for D-dimer as she's high probability. Can order duplex of the legs if possible. No need to go to CT or VQ scan. Regarding investigations, we'll do ECG and Doppler ultrasound of lower limbs. All right, and excellent. All right. Okay, so this is
Amir said a very valid point. If there's DVT, there is no point of.
Say again?
I mean, Amir said a valid point. If there's a DVT, there's no point of scanning the chest.
I might disagree with that, but go on.
I mean, it's basic. They order it anyway, so that's why.
Yeah, we will talk about that, but this is very clinical, I think. But let's talk about the approach and everything. Do you want to tell me your feedback, Zainab, as a patient? What did you feel?
So again, one had a very empathetic approach. She was, I'm not sure if you can hear me properly. I'm juggling between my phone and laptop. But yeah, so she had an empathetic approach. Again, we had an issue with time management. I felt we're spending a lot of time asking questions in a very slow manner, which we need to just try to abbreviate words, be very direct in our questions, and focus on the present complaint. So someone with chest pain, be very quick, asking about racing of the heart, where is the pain, what makes it better, what makes it worse, and any shortness of breath or cough. You missed the shortness of breath. I was waiting for it. You didn't ask me about it, or whether there is any dizziness or not. But generally, it was a comprehensive approach, but need to be a little bit faster. That's how I would say. So the history-wise, it was okay. I had some issues with the concerns bit. So there were some medical jargons used, like respiratory and OB/GYN. Patients wouldn't know what is that. Even English patients, they wouldn't know what is OB/GYN and what is respiratory. So we say chest doctor and
baby doctor or the women's doctor or the obstetrician or whatever. And I kept asking, will these tests affect my baby? I didn't get an answer regarding that.
I thought you were talking about the condition itself.
Yes, that was the first question. The second question when you said ultrasound test.
The patient had to consent.
Yes, yes.
No.
But otherwise, yeah, overall, it was a very good history.
Okay, I would. So my feedback is, Dr. Dicker, do you want to give a feedback, or do you want me to give it first?
You give it first, please.
Yeah. Okay. So
Khaled, please don't forget that Adyan also wanted to comment and we interrupted her.
Okay. Oh my God! Yeah, Adyan. Yeah, you did. Go on, Adyan. You wanted to speak. Go on.
No, I didn't have further things. Dr. Zainab actually elaborated about the abbreviation used, so that was actually my point. And I just felt one thing, I don't know if I'm in a position to give actually a feedback, but I felt that Dr. Rand, by the way, you did a great job, but when she was asking the patient, she was just asking a question after a question without actually giving the patient the opportunity to talk or to answer the question furthermore. I know it's very important to, direct the patient without getting out of context, but that what I felt is that the patient didn't have much time or not much opportunity to answer the question furthermore. Thank you.
Yeah. Okay. All right. Can I give my feedback? So from that, my own opinion, I think that you did very good. That's my own opinion. I think you covered everything. You asked everything, most of the things about the chest pain. Also reached a diagnosis. You asked everything relevant about travel, about the associated symptoms, about the leg swelling. And also, I think that you managed the time very well to the extent that you asked about everything, including smoking, family history. I know that you didn't dig deep in lots of things, but you tried to do that in the hypertension. Are you taking medication? And when she said no, you said how. So I think, my own opinion, I think you did very well. Also regarding I think that you reached the diagnosis. I might slightly disagree with some things which is clinical, which I think is not very relevant. So I think if the patient have a DVT, so you have to look for the DVT. And I think some colleagues are saying not to do because the treatment is the same. What I think that we do in acute medicine is the patient having a DVT, with the ultrasound. But if we're suspecting a PE, we have to do CTPA to see if there's any like right heart strain. But we will not skip it. We're going to start the treatment anyways. But yes, but I don't think this will make much of a difference. You start the treatment anyways. So I think you did everything right. D-dimer, we don't really do that in pregnancy because it won't be really relevant. But there's some controversy about that. But I never requested D-dimer in a pregnant patient. My own opinion, I think that you did very well, and I would score you high, to be honest, on that. I'm not sure that you missed something, and even examination, you asked about everything, including examining the patient's leg and heart. So I think this is good. This is my own opinion. Yeah, the jargons, I agree with Zainab. Don't do that. Even anyone who will not say, they will not know what's respiratory medicine. They will not know cardiologists. Don't say, I'm going to ask the cardiologist to come and see you. No, say heart doctors, lung doctors, doctors that look after the babies, doctors that look after the glands in your body, diabetes doctors, but don't say anything else because they will not get it. This is the feedback. Anyone else? Yeah, Dr.
Yes. So Dr. Rand, you have done very well, knowing that this is not the real time for Station 5, and you did very well. Yes, you have done everything systematic, more or less. The only one thing, as we all noticed, that you use the jargon, this is what we call jargon, by using OBS or respiratory physician, something which the lay people don't know that. The other thing which I liked very much, that you went through, not very systematic, but you asked about the social history, the travel she did, which all contributes to her a probable diagnosis of PE, which is the most likely diagnosis. And in my opinion, you did it very well. And I think once you practice more and more to be more with time controlling, you will pass easily.
Thank you.
Okay.
Perfect. All right. Thanks a lot, Dr. Dikra. Very useful. So should we start with case number 3? Case number 3, patient. Oh, it's Mr. John Smith, so it's me then. I'm going to quickly share the screen. Or who's gonna?
So Mahmoud is our next candidate.
Mahmoud.
Yes.
Hello, good evening, everyone.
Good evening, Mahmoud.
Yes, I am ready.
Okay. Are you sure?
Yes, yes.
All right, let's go then. Yeah, go on. So, so Mahmoud, you have Mr. John Smith. He's 50 years old, 55. You're locked in the medical admission unit. He presented with abdominal pain. I'm going to give you a couple of minutes for writing down your differentials, and then I'm going to kickstart. I don't think I have a cup of tea.
Are you doing the timing, Khaled, or shall I do it?
Yes, I am.
Yeah. So even as a patient, you will continue doing it.
I'm happy to do whatever. It's fine. It's only a phone. I stopped sharing, right, Zainab?
Yes,
There's
you
nothing. You can't see on.
Hello.
Hello?
I am Dr. Mahmoud in the medical world. Do you, Mr. John Smith, 55-year-old?
Yeah, that's me.
Yes, I try to communicate with you regarding your problem. As you find in your note, you have an abdominal pain. Can you tell me more regarding your abdominal pain?
Yeah, I think for the last couple of weeks, I've been having this pain in my tummy, and it's really annoying me. So, yeah, so this is why I came to the medical admission unit.
Okay, is it this stomach pain started suddenly or gradually?
I think it started gradually. I did not notice it until 2 weeks ago, but maybe it had been there for some time. Yeah.
Yes. Is it for how long it started? This is tummy pain.
So the pain, couple of weeks.
Yeah. Yes. Yes. Is it look like as colicky in characters, or dull in characters, or stabbing?
No, I think it's like dull aching pain.
Yes. Is it mainly at which part of your tummy? Is it at upper part, right side?
I would say in the upper part of the tummy, yeah.
Okay, okay. Sorry for hearing this. Regarding the severity of this pain, is it ranging from 1 to 10? How you adjust this the degree of pain?
I would say on the worst, it will go up to 7.
And you are requiring a painkiller. I am ready to give you a painkiller.
So I tried a couple of painkillers, but not really helping.
Okay, okay, okay. Is this abdominal tummy pain? Is it constant or return back and coming again?
Is it what? Say again?
Resolve and
yeah,
is your tummy pain, is it constant or?
No, it comes and goes.
Yes. Yes, yes. Is it associated with vomiting, nausea?
Yeah, I think I feel sick. I'm not sick, but I feel sick.
Yeah. Yes. Is there any decrease in your appetite?
No, not really.
Yes. Do you have any vomiting?
I've been sick maybe one time or two times in the last couple of weeks. Yeah, maybe. Yeah.
What's the color of your vomitings that happen?
I think it's just the yellow color. That's it. There's one time I think it was a little bit brown. You know that like the. Yeah.
Yes.
One time it was brown. The other one was just yellow.
Yes. Is it with the blood content? Sorry for.
I don't think it was blood.
Yeah. Is it like as a coffee ground sometimes?
Yeah, it might be, but this is only one time, to be honest.
Yes. Is your tummy pain increase after eating or with hunger?
So I think when I eat, things get a little bit better.
Yes. Is it your tummy pain going to other side of your your back, your other side of abdomen?
No.
No. Is there a change in your bowel opening?
No.
No. Is your pain aggravated or increased with some food or others?
No.
Yes. Is your bowel opening, there is passage of blood with your opening of bowel?
I don't think so, no.
No. This is the first time you have this tummy pain?
Yeah, I've never had anything like that before.
Okay. Do you have any fever or increase in your temperature?
No.
Change in your weight?
Second?
Change in your weight?
No.
Yeah. What's your regarding your water bath?
My what, sorry?
Water bath, is it more frequent? Is there associated with any
No, my
dysuria?
water are right. No, they are right.
No, okay. Do you have any change in your color of water work?
No.
No. Is there any change in yellowish discoloration in your face or conjunctiva?
No.
Okay. Do you have any itching?
No.
Do you have any rash?
No.
Or do you have any cough or shortness of breath?
No.
Is there any chest pain?
No.
Or racing in your heart rate?
No.
And do you have any headache, dizziness, or change in your? Okay.
No.
Is there any? Do you have any bone pain or joint pain?
No.
Okay. Do you have any past medical history regarding? Do you have any illness?
No. I just have some sciatica.
Yes. Are you using some medication for it?
Yeah.
What's the type of medication? What?
Some painkillers.
Okay. Can I see your list of drugs if you have any drugs or over-the-counter use of medicine?
I use only over-the-counter painkillers. 2 minutes
Okay.
remaining.
Okay. Do you have any? Are you having any recent trouble?
Any 1 second?
Recent trouble?
No.
Okay. Do you are smoking?
Yes.
Yes. How many cigarettes a day?
5 a day.
Okay. For how long?
25 years.
Okay. I can judge with you your smoking later on because quitting of smoking is more better for your condition. Do you are consumption alcohol?
Occasionally.
Okay. Okay. I require to examine you, Mr. Smith.
Yeah. You
Okay.
examine the patient. Everything looks fine, but there is epigastric tenderness.
Sorry for hearing this. I require to examine the conjunctiva for any jaundice.
No jaundice.
I require to examine the mucous membrane for any dehydration or if there is any ecchymosis or others or sign of iron deficiency. I require to examine the vital sign for any tachycardia or any postural hypotension for blood pressure.
Yeah, the blood pressure is 130/80. We did the line standing blood pressure, it came back 120/80, so there's not much of a difference.
Okay, I require to examine, also required to examine Tommy specifically for if there is any sign or if there is any skin rash regarding ecchymosis on the umbilicus or on one side of the abdomen.
On both sides, there's no ecchymosis whatsoever.
What?
Second?
I also examined for any sign of chronic liver disease. If there's any, yes. What's your concern, Mr. Smith?
All right, sorry, time passed. Sorry, it's 8 minutes. Okay, I'm going to give you another minute.
Smith?
No, it's the time already passed. By time you will,
yes,
and by practice you will catch that. But it's very, very, very important, Mahmoud. The concern is a crucial part of that. So you have to ask about the concern, ask about the concern, please ask about the concern. Right, I'm going to give you another minute quickly to ask about the concern. Right, so I was concerned that this pain might be cancer, doctor.
Okay, Mr. Smith, your tummy pain is, we are requiring to admit you to medical ward because we are feeling there is an inflammation in your lining of the bowel, pulley, so that we are requiring to do some blood test as well as putting for you an IV fluid. And there is another blood scanning to do for you. I think it is unlikely to be a cancer. Do you have any other concern or question?
No, I think that's it. I was just worried about it being a cancer. That's it.
As I say, it is less likely to be cancer. It is most likely to be there is a defect or a wound in your pelvis, or that we are requiring to do an investigation, and sometimes you're required to do a camera scan for your bowel to confirm this diagnosis. So that required to admit you to medical ward and give you an IV fluid and medicine and arrange you for a camera scan as an outpatient clinic.
Okay, that's perfect. Yeah, thank you. Time's over. I'm just gonna give a quick feedback because I forgot last time. I'm gonna forget now. Is when you ask about the concern, if I tell you about I'm worried about cancer, it's very nice that you're giving me the diagnosis, but always remember that patient is less likely to prompt you once again to ask. So if I tell you I'm worried about cancer, answer this question. You can say, we think it's inflammation of the lining of the stomach, and then we think it's less likely. You did that only when I asked you once again, but sometimes in the exam they will tell you once, I'm really concerned this might be cancer, and then you say, we're going to admit you, we're going to do that, but then say, we think it's less likely, or what. You have to address the concern. Sorry, I just had to do that very quickly before I forget. But should we get feedback quickly from your colleagues for all these who attended? Do you want to write down what you think, or if you want to speak, open your mic and just speak up?
Do you want to ask about just like the diagnosis?
Oh my God! Well, I think it's the other way around.
Yes.
All right. So I just forget that. I think I did not have enough coffee today. All right. So Mahmoud.
Yes.
What's happening with the patient?
Yeah, I think the patient has peptic ulcer disease due to non-steroidal use anti-inflammatory drugs. This is the first professional diagnosis.
Okay. All right. Do you have any other differentials?
Due to he has an epigastric pain that leads by eating, I think it would be duodenitis, the second diagnosis.
Yeah.
Also, I think due to the patient has back pain as well as with the this is abdominal pain, so that inflammatory bowel disease is also required to be ruled out in this condition.
All right. Okay. So what are you going to do to this patient, investigations-wise?
Yes, I require to do for him a baseline investigation, including a full blood count to assess his hemoglobin level, as well as the other parameters of blood content. I require to do for him a blood sugars, if he has duodenitis or peptic ulcer affecting his pancreas. I require to do for him a liver function test, renal function test, and assessing the score of the score of his upper GIT bleedings. I also require to do for him an abdominal scan by abdominal ultrasound to assess his pancreatic appearance. Also, I require to do for him a general stool examination for any occult blood loss, or also for this is very most important thing I require to do. Due to losing of upper GIT bleeding, electrolyte require also to be done. And I arrange the patient for OGD.
Okay, that's perfect. All right. Oh, I'm going to quickly read. Can I get more feedback, please? Because I read drug-induced gastritis or peptic ulcer. More details about drug history is very important. Okay, I think Dr. Mahmoud needs to work more on his communication skills. Also, cancer is still a possibility in this patient given his age. And I think he did not ask about the red flags. He lost time repeating the patient's condition by your tummy pain. Male smoker more than 55 should put cancer in differential diagnosis. Yep, agree on that. Okay, do you want to start, Zainab, or should I give my feedback?
Please do give your feedback.
Although I think so, I'm actually wondering if the cases are easy or my colleagues in Iraq are actually doing very well. No, seriously, I think that this is my opinion. I think Mahmoud, you did very well. Mahmoud, Rand, and Amir, the three of you are actually very good. So I think it's going well. I think you're gonna pass the MRCP if you keep doing that. So Mahmoud, I think although there's something that I might think that you missed, but I think that you did approach very well. I think you need more practice because of the not the communication, but I think the way you ask the question, it make you a little bit think, and trying to use the word sounds a little bit more complex for you. I think you just need more practice. That's it. This is the only thing that you're going to do. You asked the questions. You reached the diagnosis, which I thought that it was a little bit difficult because this patient is having gastritis secondary to non-steroidals, which you got that only when you asked about the past medical history. This is why you have to not miss the past medical history. Also, there's a trick that I put, but you did not pick up. I'm not saying that this happens at all the exam, but I tend to do that, which is if someone asks you, do you drink alcohol? And he says occasionally, you have to ask, what do you mean by occasion? Because if you have asked me, what do you mean by occasion? I would have said 6 beers a day. This is my occasional. So when someone is asking, you asked about the smoking very well, but about alcohol, you have to ask the question, what do you mean by occasion? How many? Because this can cause gastritis. You missed a little bit of the family history, but it's fine. Yes, you did not ask about the red flags. Agree, the patient is more than 55 years old, and the smoker, they might be a risk of cancer. So, but then you said to the patient that we have to exclude that, which I agree, which is fine. You won't grab everything at the same time, but on my own opinion, your approach actually was all right, and I don't have much of the things to give you. So yeah, you missed the red flags, but you refer to the concerns here, and the only thing is, please, when they tell you 2 minutes remaining, the first thing that pops into your mind is concern. I would say if you have 2 minutes remaining and you did not examine the patient 1 minute, and the other minutes should be for the concern. Because if you miss the concern, this is not, this is a big part of the, this is my own opinion. So I think, Mahmoud, I think you did very well. I think you just need a little bit of practice. And then I think that you will be able to pass the exam. You did very well. Zainab?
Yes, I don't have anything to add. Just as you said, more practice. Learn the layman term, the layman English term. That would help you, but you need to say them loud between yourself, like practice with yourself so that you can say them quickly. I think Dr. Al-Wattar has a feedback to say.
Dr. Dikra.
Then, Azizi Dr. Mahmoud, I'm going to be very honest and clear with you because I think we are all preparing for you to pass the exam. As Dr. Khaled saying that all the doctors in Iraq, which I am one of them and I have seen them, are excellent clinicians. They know more than anybody else as their peer group here. I have seen even medical students from Iraq, not even doctors yet, not graduated. They know solid knowledge more than many of the F1, F2. So I have no doubt, like Dr. Mahmoud has got the proper thoughts of what are the most likely diagnoses, and I am sure he is very good a clinician. Going back to this exam, which again I will stress every time I say, it is assessing the skill of conducting a conversation and speaking fluently and not to waste time in jumping from one area to another. For example, when I listened, of course, I did not have the time to ask him about the test. Yes, he took more time to take history, and even the history was not very thorough, knowing that the patient has abdominal pain. Maybe I missed it. How many times he opened his bowel a day? Did he have any difficulty? Does he have diarrhea or loose stool? Does he have the abdominal pain at night or only during the daytime? Is it linked to opening bowel or not? So I did not find him that he has going through the history properly for this scenario with abdominal pain. Considering the age of this patient, 55, yes, it's very important to know that he's taking non-steroidal or whatever for his back pain, but it is the age of cancer, and pancreatic cancer is very silent disease, and it may be even spread before the patient come to seek any advice. So the history is very important to take it properly, and I felt that there was poor explanation because the time was not very effectively used. Again, didn't have the time to tell the patient the differential diagnosis because that's what we expect in station 5. The candidate should tell the patient what's wrong with you, what I am going to do for you, and that is the way, but this is luck. So for Dr. Mahmoud needs to use the time effectively and practice how to speak and get the sentences and the words ready to be said rather than hesitant to find the right word to say. Because I noticed that Dr. Khaled 2 or 3 times asked, what do you mean? Because the pronunciation maybe and the way we talk, I am not surprised. I am after 30 years here, I am still, my language is not as perfect as many of the people who speaks, but at least we need to practice how to speak clearly for the sake of passing the exam. And well done, everyone. I am sure you will pass without any problem, but with a lot of practice. So thank you very much.
Thanks a lot, Dr. Rota. This is very valuable. So I would just say that take every feedback as something that you have to build on, Mahmoud, and everyone, because I had this feedback before when I was doing my exam. And I remember one of my teachers, and he's called Dr. Ramadan. I think lots of people know him in Egypt. I think most of people know. And I remember the first time I was like, come on, Callie, you're not going to pass that. He's like, literally, he was, and I was actually, yeah, I think I was actually not doing well at all. and then I struggled with the language. I struggled with the, because we don't speak English every day in our countries. We understand English, but we're speaking every day. But in the exam, you have to be fluent. You have to be able to speak English very clearly. You don't have to have an accent, like British accent, to be able to know. But you need to speak, as Dr. Waters exactly said. You have to be clear. I have to understand what you're saying, whatever accent you have. But I have to understand what you're saying. What I'm trying to say is, you're going to practice. You're just going to be there. That's it. I think we have 14 minutes. We can do one of two things: either open for questions and answers about anything, whether you want to ask about PACES or anything else, or we can do another case. I'm happy with whatever anyone chooses. You want, if someone wants, what do you think? Do you questions and answers or another case? Because actually time flies. Thank you so much for feedback. Thanks a lot, Mahmoud. Thank you. So what do you think?
He was enthusiastic. He wanted to do another case.
Yes, 100%. I'm happy. Who's going? Oh, Amir is very enthusiastic about that. Okay. Let me see if I have. I think I have another case.
We have your case.
Oh my God! Yes,
the real one.
Yeah. Can I just say something? First of all, the epigastric pain. This was my case that I passed the PACES on, which is epigastric pain. I did some tweaking around it, but this was my case, and I was not expecting, because you do lots of things, but this patient literally came with gastritis, and then and when I digged in the past case, the patient actually had sciatic and was on painkillers. So this was a real exam case. It happened in Ma'adi, in Egypt. This case is very special to me, so we can start that. All right. Is it going to be you?
This is the real case. Khaled.
This is the real case. I saw this patient 6 months ago.
I'll be the patient because she's a.
All right. Yeah, I'm going to just start with time. Is it Amir?
Yes.
Yes. Yes.
Amir, are you ready? Okay, Amir. Give me 1 second to put the case up. Give me 1 second. Can you see it now, Amir?
Yes. Can see it. Yes.
Yeah, so it's Miss Kirsty Valentine, 62 years old lady, presented to the emergency department. You're one of the doctors in ED, and they asked you to come and see this patient. Came with hemoptysis. The respiratory rate is 23, heart rate is 96, blood pressure is all right, no temperature, saturation is 92%, and the patient is on 2 liters of oxygen at the moment when you're seeing her. All right, I started you the 2 minutes. And by the way, these are not real names, just to be clear. I'm going to stop the sharing. Zainab, I'm not sharing anymore, right? Perfect.
Leading the timing fund.
Yep.
I'm ready, Dr.
Are
Khaled.
you ready?
Yes.
I'm going to start now. You enter the room.
Okay. Good evening.
Hi, good evening.
My name is Dr. Amir. I'm one of the doctors here. Can I confirm that I'm speaking to Ms. Christy Valentine, 62 years old?
That's correct, yeah.
Nice to meet you, Ms. Valentine. So, Ms. Valentine, we are here today to discuss about your recent symptom. Would that be okay with you?
Sure, yes, please.
Can you tell me what seems to be the problem?
Well, I've been coughing up blood recently, which I'm really worried about.
Okay, I'm sorry to hear that. So, is it your first time coughing up this blood?
Yes,
or?
Yeah, it's my first time, yeah.
Okay, and for how long you have been coughing up blood?
Just for a few days, it hasn't been for a long time.
Okay, and how much can I ask? Is it like tablespoon size or?
I would say roughly, yeah.
All right, and on every time you cough, you pass or you bring up this blood?
Not every time, no.
Okay, and is it gradual in one sense or suddenly?
Well, as I said, it started suddenly like a couple of days ago, but I didn't have any issues with that before.
Okay, and regarding this cough, this is your first time having this cough only for a few days, or is it like a regular cough you have?
I have occasional cough, but doesn't come up with any blood in it.
Okay, and is there any history of temperature, any high temperature?
Yes, I've been
Okay.
feeling hot recently.
All right, only for the past few days. Okay.
No,
and
more than that, I would say, for the last couple of weeks.
Couple of weeks, all right. Is it more in the night or in the morning or all over the day?
There's no specific time.
All right, any
Generally,
sweating?
Yeah, I do sometimes when I feel quite hot, I feel sweaty as well.
Okay. Is there any night sweating especially?
No, as I said, there's no specific time.
All right, any weight changes?
Yes, I've lost some weight. I regularly weigh myself and I noticed I've lost some weight.
Okay, is it intentional or unintentional?
No, I'm not on any diet.
All right, and what about your appetite?
I'm not feeling that I really like to eat.
Okay.
I feel my appetite has been changed recently.
All right, and is there any lumps or bumps in the body?
I haven't noticed anything.
Okay, any problem with your water work?
What kind of problems?
Any like bloody water work? Have you noticed any blood, any pain?
I did. I noticed I had some blood when I was passing urine the other day.
Okay, and for how long you have noticed this?
Just for once or twice.
Any change in the amount?
No.
Okay, back to your chest symptoms. Do you notice any shortness of breath?
Yes, I do. I feel short of breath.
Is it related to any position?
No.
Okay, so you don't have any trouble sleeping at night?
No.
All right, any chest pain?
Yeah, there is chest pain.
Okay, is there any past medical history of note I should be aware of?
Well, I am being investigated for a chest problem. I'm not sure what it is. Some say it's asthma, some say it's COPD. But it's still under investigation, so I'm not sure what it is.
Okay, and can I ask you, do you smoke?
Yes, I do.
And for how long and for how many cigarettes per day?
I smoke 20 a day, and I've been smoking for the past 40 years.
So, Ms. Valentine, I think smoking can be bad for your condition, and we will address this in a separate discussion. Will that be okay with you?
Yes, yes, no problem at all.
All right, and any joint problem?
I've been feeling generally achy.
Okay, all right, so any muscle pain?
No, as I said, generally I feel my body is aching.
Yes, okay. Have anyone commented that you look pale?
I haven't heard that yet.
Any pain in your legs or swelling in the legs?
No.
Any travel recently?
I haven't traveled anywhere.
what is your medication list? Are you on any medication at the moment?
Well, I'm on aspirin, and I take some inhalers for whatever problem I have. And that's
All right. Okay. And do you have a past history of a clot problem?
No.
Okay. Can I examine you? I need to examine the hands of the patient. Is there any clubbing and nicotine staining?
Yeah,
Okay, I want
clubbing. Chest is some crackers on the left side, but nothing more. You've seen blood that she got already in the pot, and she's on 2 liters of oxygen, and the blood pressure is all right. You did the urine, came back with bloods in it.
With the blood in the urine. All right. You said for the respiratory there is the crackles on which side?
There's a little bit of crackers on the left side where she had the pain, and you notice some rash on the tummy.
All right. Okay. And is there nicotine staining and is there clubbing?
No.
No clubbing. Any flabbing tremor?
Second?
Flabbing tremor. Any pallor?
Any?
Pallor, pale conjunctiva.
No.
Okay. I want also to examine the legs for tenderness in the calf or swelling in the calf, maybe.
No, nothing. Sorry, I said crackers on the left side, and she's a little bit wheezy.
Little bit wheezy on the crackles on the left side. All right. And okay. So Ms. Valentine.
Yes.
Ms. Valentine.
2 minutes
okay.
remaining.
Okay, Ms. Valentine, do you have any concern for me at the moment?
Well, to be honest, I'm in pain at the moment. Is there anything you can give me to relieve my pain?
Okay, I'm sorry to hear that, Ms. Valentine. Of course, I can give you painkiller before we proceed any further.
Thank you. And I'm worried, is this a cancer?
So, Ms. Valentine, from our discussion and from our brief examination, cancer here is a possibility. This is very important to rule out at the moment. That's why it is very important to admit you now and to do some blood test and do some imaging of your lungs maybe. And then we will rule out, we will have another discussion to discuss about the recent. And also I have other diagnoses in my mind I have to rule out. Would that be okay with you?
Yes, please do whatever you can to help me.
Okay. So any other concern?
No, I don't have any other concern.
All right. And I didn't ask you, Ms. Valentine, are you married at the moment?
Yes, I do. Yeah, yes, I am.
Okay. Do you have anyone support you at home? Are you supported?
Yes, I live with my husband and children, and they are all supported.
And they are healthy at the moment?
Yes.
That's good. And okay. Any other concern?
No.
All right. And okay.
That's it.
All right.
Thank you. Thank you very much. All right. Tell me, Amit, what do you think about what do you think what's happening with Miss Valentine?
So we have Ms. Valentine, 62 years old, with a background of heavy smoking, presented with a history of hemoptysis for the past few days, and also coughing. She also have a history of weight loss, fever, and sweating, and fatigue and anorexia. So my top differential diagnosis would be a case of bronchogenic carcinoma. On the top maybe of background of COPD maybe. This is the most serious diagnosis I want to rule out because she has a lot of risk factors. Another thing I will also have to rule out bronchiectasis. So it is very important now to admit the patient and do imaging and chest X-ray, CT scan of the chest and other investigation in the form of ABG. And,
are we going to admit the patient?
So maybe to the short stay unit, but yes, to do at least, because the patient is now having hypoxia and low saturation, yes, it should be admitted at the moment. She should be admitted and to rule out sinister diagnosis.
All right. Okay. I think you also addressed the diagnosis. Any other differences in your mind?
So after bronchogenic carcinoma, I would put bronchiectasis. I also want to put pneumonia, maybe.
Yeah.
Yes, a chest infection, and also pulmonary embolism could be added.
All right. Okay. Yeah. Perfect. Thanks a lot. Thanks, Amir. Should we take a quick feedback from the team? TB also has differential diagnosis. That's very good. Yes, TB, lung malignancy, and
Yes, TB.
I'm just reading from what your colleagues writing. Lung malignancy, TB, and did not ask about the dosage and frequency of aspirin. Yes, good point. I think vasculitis should be considered Wegener's. Who's that? Mustafa Al-Obeidi. Thanks to Mustafa. And anyone else? Any more investigations, please? Yes. I think he mentioned that, but yeah, I did not ask about this. So, Amir, what are you going to offer as investigation for the patient?
So for the investigation, I will start with the complete blood count, looking for anemia and leukocytosis, PSRC reactive protein, liver and renal function test, and also electrolyte. I will send for chest X-ray and maybe high resolution CT scan to rule out lung cancer or bronchiectasis. The patient is having also hematuria. I will also need to rule out pulmonary renal syndrome to look for vasculitis as well. I will send at this age of the patient, I will send for PNK and CNK to rule out vasculitis and Goodbuster syndrome as well. And I will also send the patient for sputum for analysis for fast bacilli. And of course, I will send for APG and pulmonary function test after she is stabilized.
Oh, that's good. So, anyone else want to give a feedback? Zainab, do you want to give a feedback?
Yes. So Amir, excellent history, excellent approach. As we said, there is a remarkable improvement, and there is an empathy with the patient, which was clearly evident in your history and your approach. I liked the fact that you asked about important negative, any history of clot, which was quite relevant, and I liked this bit when you did it. When someone tells you that there is a history of hemoptysis and hematuria, please don't forget to ask about vasculitis in your history. You did ask about the joint, but you didn't ask me about any skin rash. And when you were
I'm sorry, I did ask you about a rash.
You did. Sorry,
I said any rash.
My fault. Apologies. Just the other thing, when you were summarizing the history to Khaled, you said history of fatigue. I didn't say anything about fatigue, so don't add anything. I didn't say any history of fatigue. I said I was generally achy, I've lost weight, I haven't been eating well, but I didn't say anything about feeling quite tired and fatigued. So don't add anything that's not mentioned in the history, because you'll be adding signs and symptoms which are not present. But generally, I quite like the bit that you mentioned, asked about the social history, which was quite excellent. Any family support was excellent. But generally, overall, it was an excellent approach, and I personally think we'll pass this easily.
So for the fatigue, you said you have been not feeling the same.
Yes.
Interrupted it as a fatigue or maybe tiredness.
Don't interrupt. All right, well, I think it's what Zainab means is just use what the patient's saying rather than saying something else. Can I just tell you something very quick, Amir? I think, and this is the great thing about practice. My own opinion, I don't know if anyone agree with me or not. This case, in comparison to the case before, there is a complete. I think this one, I would say this is the perfect case. So I don't think that I would have done it differently, or anyone have done it different. I'm not saying I'm right, but I'm saying this is a perfect PACES case, and I would give you 28 out of 28. It's my own opinion. I'll give you 28 out of 28 of that. You asked all the relevant questions, although I can't really mark you on the investigations because you read all the all the comments from your colleagues before asking you about that. Mustafa, there's someone called Mustafa who said, Mustafa Al-Ubaidi, I hope I'm saying it right. He said, I think he said, give me 1 second. Mustafa says something very interesting. Vasculitis should be considered Wegener's. Yeah, I'm just saying that, Mustafa, I've seen a case like that. It's not the exact case, but this is a case. I think what he said, Wegener's was actually the diagnosis the patient had Strauss, because the patient had a history of asthma, and there's not asthma, but the patient was a little bit wheezy, and there's urine there's blood in the urine, and the patient came with hemoptysis. So vasculitis was actually the diagnosis of a patient. I've seen that. This is how I put this case with a patient I've seen, like not exactly like that, but I've seen a patient who came with hemoptysis, blood in the urine, and we thought at that point it was a PE, and it's actually a vasculitis. PE is a very good differential. You should put that in your mind. You should do an ABG for the patient. Always remember to do that. But I wouldn't imagine you doing better than that. I mean, I think very, very well done. And this is what I'm trying to say, practice. So you practice now, you've seen a couple of cases, and then you did another one now, it's perfect. So I think if you practice every day until the exam, you're gonna be good. And if you feel now that, oh, actually I'm all right, do it more, because you need more practice, because you need to be more automated when you go seeing the patients, because in the exam we're slightly more stressed. So you want to get the way you think, which I think is number one, just quickly knowing what you're doing, everything is on your mind rather than thinking of it specifically. Your communication is very good, and you always address the patient's concerns very well, and you said, oh, we should stop here and give you some painkillers, which is something I like, because we sometimes tend not to do that. So yeah, my own opinion, I think you did very well, but still I'm going to wait for Dr. Al-Wattar to tell us her opinion. Dr. Wattar, do you want to tell us your opinion?
I think I just commented, I think Dr. Amir has probably learned a little bit from the previous scenario, and he's been addressing everything perfectly. I know it is not a real station 5, but despite that, he's done very well. And I think, as you said, practice will make him more fluent in the exam, and I'm sure will sail through the PACES easily, inshallah. And inshallah, all of them sail very easily through the exam. Yeah. But nothing comes easy. They have to practice and learn the way is expected in the.
Thank you, Dr. Anyone have Zainab, do you want to say something, or because you approached it? All right. Okay. Anyone have any? Amir, do you want to say something? Do you want to?
Yes. Yes. I want to ask you something. Yeah, so with the case of diplopia, if we are examining the patient for diplopia and we discover there is diplopia, should we go like to do the cover test and or only just to offer? Because I hear some mentors only to offer with the discussion with the examiner about the cover test.
What I do is, when you examine the patient, so I say that you always have limited time, to be honest. So I think I'm going to leave that to Dr. Wattar, which is an examiner, she can decide, but I would not do that. I can say, I can examine the patient, and then I will say, I'm going to do the cover test. This why I will do it, because I don't really have much of a time. But yes, maybe Dr.
Because Wattar, it will take time, because if we are alternating between the right and left eye.
Yeah, so I would just, yeah. So Dr. Wattar, what do you think?
Yes, I think in the exam, the lead examiner will direct you on what to do, knowing that the time is very limited. So when you say, I want the ophthalmoscope to look inside the eye, we'll say no need, because it's either normal or nothing. If you say, I want to do double test, if the time allow you and you have not done something more silly, we will allow you to do that, if the time allow you. Otherwise, they will lead and say no need to do that, and they start the discussion. So it all depends on the time itself and what do the examiner think at that time. They may not want you to do any of these tests. but at least you have to offer them and say, I want to show your knowledge that these are the tests we do when we are faced with a case of double vision or loss of vision or whatever. A very important note for as we talk about the visual loss, whoever candidate go into that station, and that's what we expect, either rheumatology or endocrinology or eye case, they should notice if there is, like in UK and maybe in Iraq also, if there is a white stick or if there is a dark eye glasses to wear, to know that this patient is probably partially blinded or partially blind or a blind man, because these are the hints to assess. And also not to forget, when you assess someone with visual loss, make sure the candidate don't miss artificial eyes. And it comes in the exam very commonly, especially if in the abdominal case, there is a probable liver tumor or melanoma, and the right eye was like artificial eye because they inoculated the eye and put a artificial eye for that. So people has to be very careful on and to notice what is going on, to give them a hint of their probable diagnosis and differential diagnosis. So I'll stop here now.
Thanks a lot, Dr. Wattar. Ron, you had a question?
Yes, my question to Dr. Al-Wattar, I'm still struggling with murmur. So in the exam, if I couldn't pick up this murmur, is it systolic or pan-systolic? How to deal with this? Will it affect the diagnosis, or can I pick the diagnosis from other clues of the patient?
Rand, I have noticed from the scenario you had, you are excellent, doctor, as everyone. In this exam, in any station you go, you have to be honest in what you hear and what you don't hear. Don't make up things when you are not sure of it. So with regard to finding a murmur, it is in the exam, they will not bring you very murmurs which the two examiners cannot pick. They are very straightforward. It will come in the exam either ejection systolic or pansystolic, and it depends on the site and the way you examine the patient. If it is ejection systolic, you have to listen to the neck to see if it is radiated. And if it is not radiating, is it just simple aortic sclerosis? And you have to make sure that is the case. If the murmur is more extending from the first heart sound, and it is more here towards the left axilla, you might think, I think this is pansystolic, and it is most likely either mitral regurgitation or something like this. If it is in the left parasternal area and it is pansystolic, you have to think, is this VSD, for example? These are the things comes in the exam. And make sure, please, I have in the last recent exam, someone came with the shortness of a breath and cough and some hemoptysis. So please examine this patient. And it was in station 1. In station 1, the patient was examined and then everything was done, and they could not hear any crackles in the chest, although the patient had the crackles on the left side. And then because we knew what is the condition, in the scenario, I mean, we said this patient is like having shortness of a breath and hemoptysis. This patient, in the discussion, I asked the candidate, where was the apex beat? Yes, it is respiratory case, but I just wanted to see whether they felt it. And that candidate said it was not deviated, it was in the mid-clavicular line. And believe me or not, this patient had dextrocardia. So making up things is not on your side in the exam. And the two examiner has to agree to what is well recognized or not well recognized. So if it is pansystolic, and me and maybe with Dr. Khaled or Zainab, we hear the pansystolic, we have to write pansystolic. Radiation, we have to write. all these things has to be very clearly documented, and the candidate should not be failing to recognize pansystolic from ejection systolic. You should know that we really appreciate nowadays, even with all my respect, maybe Dr. Hilal and other cardiologists are here, even some very prominent cardiologists don't use their stethoscope anymore, and they may send them for echo. So I think it's very important to know the basic pansystolic, ejection systolic, the way it radiates, and don't make up clinical signs which are not there or not very clear, and that will make you very safe to pass the exam. I hope that answers you, Rand, and you are a very good doctor.
Thank you
And
so much, doctor.
truly,
Thank
the
you. We
way
really
you-
appreciate your presence. You were supposed to travel and still you attended with us. Really much appreciate your time. Thank you so much.
Because I want you to all know what are the tips to pass this exam, because as we discussed early, Dr. Khaled knows you are excellent doctor. All what you need is the finishing touches and the way you present yourself in the exam. So good luck, and inshallah all of you pass.
Thanks, Dr.
And before I go, so to you, Dr. Khaled, and to Zainab, I am so thankful, very grateful. I even learned from you.
Oh, bless you. Thank you. This is an honor to be there from
Thank you for the presentation.
Thank you very
have
much.
to know how to speak the English fluently, although it's a bit late for me, but you are very good.
No, you are a teacher. Come on.
Okay,
No,
good
thank you very
luck,
much.
everyone. Nice
Thank
to see you. We'll meet again, inshallah.
Inshallah. Does anyone have any other questions that you want to ask us? Anything? I would put up my email. If you want to contact me for anything regarding that, I'm just happy to reply with the email. That's my email, Abuelenain@nhs.net. Once again, I told you I was literally wearing his shoes a few years ago, and I was taking my exam, and I thought it's always a little bit difficult. I'm not going to pass this exam, but if I pass it, that you all can pass it. So take it easy. You're going to do fine, and I think that you're all going to do fine. And you don't have, so we're not all the same. So some people might be more fluent than someone else, or examining the patient, asking the question. Some will be a little bit slower, but then practice will make us all pass the exam. So please, as Dr. Waqar said, practice, practice, practice. What significance? What significance of flow murmur? Is that question for? So I think as Dr. El-Waqar said, usually in the exam, you will have very clear murmurs. In my case, I saw, for instance, aortic stenosis. I think yes. And so usually you will not be presented with very complex cases. So I think it's less likely for you to get these things, but I'm not sure about the significance of murmur. Flow murmur, do you know about that, Zainab?
So, I mean, they don't really, even if you could, because we need to remember that sometimes they put normal patients with normal heart.
Yeah.
You just say what you hear. If you can't hear a murmur, then you can't. If you hear.
And you can say that, to be honest, you can easily say that I heard a murmur, and I couldn't really. Definitely, you'll know the difference between systolic murmur and diastolic murmur. So you can just say systolic murmur. I can't really hear it radiating anywhere, but I would like to confirm my diagnosis by doing a heart echo. If you always say that, this is a very good answer. If it's very clear, as Dr. Waqar said, if this is a systolic murmur going to the neck and radiating, and you say I can't really hear anything, it would be. But if it's a systolic murmur, you're not sure if it's radiating or not. Just say that. Simply say it. And this is what we do actually in practice. In practice,
show that they are doing the effort to time the murmur. So you need to palpate the carotid pulse when you do that.
Yeah.
Showing them that you're doing this effort to time it, but you couldn't. At least you've done the steps. Time it and accentuated by doing the maneuvers related to it.
They say that hypodermically, yeah, this is the format. So yeah, but we just the significance of it in the exam. You mean this was the question, right? Because not in life is not significant. So if the patient came with you just did aortic valve replacement, for instance, you would have a flow murmur, or yes, anemia and pregnancy. I agree, but I don't think in the exam. If you picked it in the exam, you can say it. But I would say I heard a systolic murmur. If it doesn't have any other symptoms, you say, yeah, I heard a systolic murmur on the aortic area, not going anywhere. I would like to confirm my diagnosis about doing that. That's it. All right, any other questions? I think we have. No.
We can wrap up now.
Okay, thanks everyone for listening. Really much appreciated. Thanks a lot, Zainab, for taking all that.
Thank you, Khaled.
I think she thank you very much for actually giving this opportunity. And all the volunteers, thank you very much for actually stepping in, because yeah, I think it's a little bit stressful, but have the stress now, because in the exam, it will be easier for you when you do. This is the good thing about the mock exam is mock, very stressed, everyone's watching you, and then in the exam I did that before, so that was great effort. All right,
Thank you so much, Khaled. We appreciate it, and thank you everyone for staying up late with us, and we
okay, I hope to see you all at some point in the UK, inshallah. Dr. Hilal, thank you very much.
Thank you.
Thank you very much, dear Dr. Khaled. It was an excellent interactive session, very useful and very informative. Thank you also for Dr. Zainab for organizing all these sessions, and we hope it is useful to our candidates. Thank you.
All right, thanks a lot. Thank you.
Thank you so much. Thank you.
Yeah, تصبحوا على خير.
صباح الخير.
وحضرتك من أهل. صباح الخير.